Okay, good morning, good afternoon, good evening, clinical problem solvers. We're back for another neurology morning report. Nice to see everyone. It's going to be an awesome day because we have Andrew presenting and both Valeria and Sarah, current neurology residency applicants, soon to be neurology residents, going to be co-discussing. So I'm super excited. Um, Unlike last time, I will probably have to stop closer to 9 this time, despite our usual trend of just discussing neurology all day if people are available. So don't give us anything away, Andrew, but if there's a point where you say, there's a lot more to this case, you might want to move along, something to that effect. Last time we spent a lot of time thinking we were getting to the final diagnosis, and then the patient came back to the hospital 11 times or something, and we rushed through a lot of medicine in 3 minutes. So I'll just put that out there that we're aiming for a 9-ish conclusion. So let us know if we're. I always go off track, but if I'm even more off track than is usual for this time frame.
Great. That sounds good, Aaron. It's 5 aliquots of information. Good to see everybody, by the way. I haven't been at Neuro VMR in a long time. I don't think I presented a neuro case. This is a pretty challenging case. This is a Vale and Aaron level case. So I'm happy to bring you guys some joy through this morning. And sorry, it is a lot of information. So just bear with me as I go through each aliquot, okay?
No
But
worries.
aliquot number one is the HPI and past medical history. So it's a man in his 70s who came to our hospital with bilateral leg weakness. He couldn't notice when exactly the weakness started, but he thinks it began no more than 3 months prior. He decided to present because after being unable to stand up from a chair or climb stairs without significant assistance, he then, even with a walker, had difficulty making it from the bed to the toilet. So he had to start using a bedside commode. And then for other symptoms, he's noticed he had worsening loose stools that he calls frank diarrhea, and this began a few weeks prior to admission. He had not had fevers or chills, no abdominal pain, no dyspnea, no joint pains, no rash, no changes to sensation in his body, no memory or cognitive changes. And he follows a neurologist who noticed that he had some bilateral resting action hand tremor, and this was felt to be drug-induced Parkinsonism because he was on 20 years of perfenazine, and they basically stopped that medication for this resting tremor. But he's otherwise noticed frequent coughing, often at night, lightheadedness on standing, one episode of urinary incontinence, and 10 pounds of weight loss. And he just describes feeling stiff in both arms. So for his past medical history, he has bipolar disorder, for which he's now on quetiapine. He had a GIST tumor, prompting a Whipple's surgery about 4 years ago. He has diabetes. A1Cs are well controlled for the last 5 years. Hypertension on just one medication, and CKD without a clear endpoint diagnosis. And he doesn't smoke, and he has no family history of early cancer or autoimmune disease. And I'll stop there.
Okay. All right. Very good. We have Valeria and Sarah. Would one of you like to let's talk about bilateral leg weakness? I know we have more information than that, and maybe in your discussion of bilateral leg weakness, you could mention whether any of the information we got helps you. But just talking about the general localization of bilateral leg weakness. Or do you have any other questions for Andrew before we decide that that's what we should be discussing?
Yeah, I have one quick clarifying question. With respect to the bipolar disorder, how recently was that diagnosed? Um,
Very remote because I think he was on that perfenazine for yeah a long time.
got it.
Awesome. Sorry, you want to take it away with the bilateral lower extremity weakness?
Sure. Um, well, I think in terms of the localization for lower extremity weakness, we can localize it to either like spine or brain. I think for this patient, I would be thinking about whether there's kind of an insidious, kind of chronic to subacute process that's going on that we're not picking up on. Um, and I I'm a little bit intrigued because he has this kind of progressive tremor plus what sounds like maybe and it was negative for weight loss, right? Uh, but he did have bowel and bladder problems, so that could localize to a spinal concern as well. Um, I know that there are some kind of autoimmune conditions that can present with both kind of the weakness picture as well as bowel and bladder. I think it might be DPX 4, maybe, but not to kind of move too quickly to a diagnosis before localizing. So those are kind of my first thoughts. Valeria, do you have to add to that?
No, yeah, I'm rather with you. I love how you use the urinary incontinence to kind of think, okay, is more localized to like the spine. Because yeah, when it comes to like bilateral lower extremity weakness, I think about the corticospinal tract, like you said, going from the brain down to the spinal cord, but also thinking about the roots and the neuromuscular junction, or sorry, the nerve, the neuromuscular junction, and the muscle itself. I think when Andrew mentioned that he couldn't stand up from a chair, I was concerned with like proximal weakness at the beginning, which we usually associate with like more a muscle problem. However, it's very true that muscle problems should not usually come with like urinary incontinence, and the stiffness is also a little odd for me. So where would I localize this? I think we have some clues. The urinary incontinence for sure leads me more to the want to rule a myelopathy versus a peripheral nerve problem, for example, in the territory of CIDP. That would not be typical to present with autonomic symptoms. But then we also have some signs of, as you also said, more like an inflammatory, autoimmune, or more like even a systemic thing going on with the weight loss. With this patient that has a history of malignancy, could this be a recurrence that is, affecting the CNS now, and or could this be something just inflammatory, causing weight loss? So yeah, I think I'm also thinking about the spine and would be very interested on the exam to look for signs of like upper versus lower motor neuron disease, and to characterize better this stiffness, because with the also think about like Parkinsonism on the backstory, it's also, I think, tricky to differentiate what's noise and what's signal. So yeah, those are my thoughts, and would love to hear your thoughts, Aaron.
Yeah, brilliant thoughts from both of you. I think, yeah, the exam's going to be very helpful here. If you take bilateral leg weakness at face value, as you both said, this is in general spinal cord or below, and rarely brain. So it could be cord, it could be cauda equina. We often forget the cauda equina, and they're the lumbosacral nerve roots. Could be nerve, neuromuscular junction, or muscle. You might say, well, if it's a nerve problem or neuromuscular junction or muscle problem, wouldn't it be the arms also? But I think the legs are sort of more noticeable for patients early on because of gait, and proximal arm weakness you might not notice unless you're really reaching up to a high cabinet or something. And there is this arm stiffness here. Is that really an expression of weakness? Or are we really dealing with bilateral leg weakness? But at face value, bilateral leg weakness is spine or below, and as you both did on exam, we'd want to know about upper versus lower motor neuron signs versus no reflex signs, which would put us more as true weakness in the neuromuscular junction or muscle if there's no sensory features. And then very rarely, midline parasagittal lesion affecting the leg areas of the homunculus can trick people. That's if this is truly bilateral leg weakness. We can wonder, because the arms are stiff, are the legs really weak, or are they stiff, or are they ataxic, or patient has said weakness here, but there's a lot of other stuff going on. So we talked about how we might distinguish first pass, it's bilateral leg weakness. We all think spinal cord, spinal cord, spinal cord. I like to think spine because it's spinal cord or cauda equina for bilateral leg. And just remember, can also be below nerve root, nerve, neuromuscular junction, muscle. Nerve root's the cauda equina. And then as you both clued into, there's bowel and bladder. You shouldn't get that with nerve, neuromuscular junction, muscle. Oops, I don't know why I just had a thumbs up icon float across in my gesticulation here. That bowel and bladder would make you think more of spinal cord or cauda equina, unless you have a really big, frontal lesion that's then giving you incontinence as well. So a little interesting that it's described as diarrhea. Is that really incontinence? That's some sort of overflow incontinence from autonomic dysfunction of the bowel. I don't know why. Usually it seems to me, others can chime in, that with neurologic bowel and bladder dysfunction, the bladder is just much more prominent for the patients with a lot of urgency and overflow incontinence and retention. and bowel is maybe sort of less obvious because maybe people's bowel habits vary a little more based on their diet day to day and their hydration, whereas urination is sort of pretty constant thing we do all the time. I don't know the answer to that, but there's not much urinary, one episode here. Hard to know what to do with that bowel and bladder piece. As Sarah said, is it diarrhea from a GI? You mentioned DPPX. I've never seen a case of that. I think you mentioned one of these perineal. I think it's usually perineoplastic, or it's at least immune mediated. It's like dementia, diarrhea, and movement disorders, or something like this. One of these more recently described antibodies. I haven't seen a case. Very rare. And then there's just a lot of other stuff here. There's weight loss. There's the stiffness. There's so we talked about bilateral leg weakness. I wanted to talk about that because I think it has a localization and differential of the localization worth discussing. But if we now just sort of say we have all this stuff, how are you all putting this together? Are you lumping or splitting?
Yeah, I think for me, the tendency is always to lump. And I think it's also fair to, as you said, we are not really sure if the legs are the only things affected. We could be, higher on the spinal cord as well, and that could also lead to like some stiffness on the arms. Or like a multifocal spine process is also fair. I see that Andrew pointed out in the chat that he also had like nocturnal cough symptoms, and that was very interesting to me because coughing during the night is not something that I've encountered, but for some reason made me think, could the brainstem be involved as well, or like the cervical spinal cord, like to kind of irritate for some reason the diaphragm and lead to cough, or through the medulla, the vagus nerve or something like that. And I don't know. What do you make of that? Because for sure, those more like esoteric symptoms are the ones that I'm having more trouble localizing to the spine.
Yeah, I agree with you. It's pretty rare to get diaphragmatic involvement in neurology. You do see it from phrenic nerve pathology. We had a case recently, someone showed me, not here, but at work, of a patient with a brachial plexopathy, an inflammatory brachial plexopathy called Parsonage-Turner syndrome, that had elevation of the hemidiaphragm on an x-ray, and the patient had presented with sort of orthopnea and arm pain. You do see it, but I mean, the diaphragm's so important. There's a phrenic nerve on each side. I think the body does its best to preserve that function. So I don't know about that nocturnal cough. I'd have to dig deep into my mental closet for my medicine hat and put it on and wonder, is this paroxysmal nocturnal dyspnea or some type of orthopnea from the heart? Or you can get the symptom of orthopnea from diaphragmatic weakness. And then, I usually don't think of that so much with brainstem. Maybe you're thinking more of sort of a central sleep apnea, Ondine's curse. That's a pretty rare, as you said, kind of gourmet, esoteric thing. So, I feel like someone told me maybe one of the internists here knows this. Cardiac orthopnea versus diaphragmatic weakness orthopnea. There's like classically the time after lying down that you start getting orthopnic is quicker with one of them than the other. Does anyone know this? This is ringing a vague bell of some senior medicine person giving me this pearl, and clearly it doesn't come up often enough that I remember. But someone can maybe look it up and see if I would guess if it's the heart, it takes a little while for your fluid disequilibration to occur, and then you start feeling orthopnic. Where if it's the diaphragm, as soon as you lie down, your diaphragm is more superior, and and it's more instant, or something like this. Someone can fact check me on this. I don't remember. Okay, so maybe there's some diaphragmatic weakness here. So you want to lump this, and if you were lumping it, what are you lumping it into? I mean, what is there? Are there any unifying diagnoses that are coming to mind? Or should we wait till after the exam? It's up to you.
I mean, I'm happy hypothesizing. I don't know, Sarah, if you have any thoughts, but I think maybe something a little maybe multifocal on the spinal cord, or something high on the cervical cord that for some reason is just presenting right now with like lower extremity weakness, but also like the stiffness on both arms. So like that makes me suggest that maybe something higher can be going on.
Yeah, not sure what to do with that stiffness. If there's, as Andrew mentioned, drug-induced Parkinsonism, or if the stiffness is, as you said, sort of more spasticity, upper motor neuron part of this whole thing that we keep circling back to the spine? Maybe. Or not. Yeah, what are you thinking, Sarah? Are you lumping all this, splitting it?
I
Not
think
sure.
right. Yeah, not sure right now, but thinking that initially I'd like to split the kind of more Parkinsonian symptoms into a different syndrome than the weight loss and lower leg weakness, because it seems like maybe there's a different time frame and maybe um, different triggers for them. I think the other thing that I would want to know is, does he have any evidence of kind of metastatic disease from this prior GIST? Because that could be maybe a unifying thing for at least the cough, like lung mets plus spinal mets and brain mets. So I would definitely want to have a good spinal exam, see whether there's any point tenderness or anything of that sort, and um, yeah, and get more about his onc history.
Yeah, great thoughts. I think one question here is, do we lump or split the medicine and the neurology? And then do we lump all the neurology or split some of the neurology? So you were saying, Sarah, there may be, and we'll see this on the exam, so we should probably head to the exam after this. There may be, yeah, there's some drug-induced Parkinsonism, this tremor, this stiffness, that is, we can split it off, and it's not part of this presentation. And then there's bilateral leg weakness and maybe some diaphragmatic weakness, and we may want to make that a package. And then the question is, okay, we hear weight loss, the patient has a history of cancer. Does the patient have cancer and METS, cancer and paraneoplastic syndrome? GIST, I don't think of as really uh, metastasizing to, at least I've never seen it go to the neuraxis. GIST and paraneoplastic, anything can do anything. But paraneoplastic neurologic syndromes we love to invoke on our zebra hunts, but they're actually extremely rare, probably aside from thymoma myasthenia. But the ones like paraneoplastic encephalitis, all these, pretty uncommon. So yeah, the time course here, sort of subacute, sounds sort of neoplastic, immune mediated. Um, Other possibilities here, what if the weakness in the legs, couldn't get up from a chair, is sort of a proximal weakness, myopathy kind of picture? Then is there a cancer with dermatomyositis? We're not hearing about a rash, though we were specifically told there is no rash, so someone was thinking about it, or maybe we're just getting a more complete medicine review of systems than our usual neurology fare here. I'm not sure. Yeah, I'm not sure where to put this. I would probably be going to the exam, not sure. And these are some of the questions we have. Is the problem in the legs true weakness? Is it proximal or distal? Is the arm involvement Parkinsonism, or is it weakness, spasticity? Are there upper or lower motor neuron signs? These are some of the things we're thinking about going to the exam. Then after the exam, we should be able to say at least, okay, this is a spinal cord problem, or this is a cauda equina problem, or this is neither of those. This is a muscle problem. There is or is not Parkinsonism. This is over months, if I remember, so it would be fast for a degenerative condition. We heard some dysautonomia, some Parkinsonism. You might wonder about multiple system atrophy, but the leg shouldn't be weak, although again, is weakness just the patient's word for something we'll find to be Parkinsonism? And then that would explain really the weight loss. It would, like I said, be a little bit fast for that. And then it is morning report, but we can't forget the possibility of just sort of multifactorial common things all kind of overlapping to create a complex picture. So does this patient have just some progressive cervical spine stenosis on top of some drug-induced Parkinsonism, on top of recurrence of a systemic cancer, and everything gets split apart, and the neurology is actually something kind of every day, and we see this. I find I'm noticing this a lot more, some of these challenging cases where it's like, oh, if you saw the diagnosis on paper, it's a very straightforward, it's like a peripheral neuropathy and cervical spondylosis, or it's Parkinson's and it's lumbar stenosis. But the combination of those two in the context of a patient with a lot of medical disease, it is sort of, I call it like complex bread and butter. Like it's bread and butter on paper, but the gestalt is confusing when things kind of overlap and combine in unique ways. Okay, let's hear the exam, if we may, Andrew, and hopefully that'll give us a localization and get us all more on a direct path here than one in which we are winding in and out of the labyrinth of possibilities.
I like complex bread and butter. That's definitely what fools me the most nowadays. All right, so for vitals, he's afebrile, normal heart rates, 130s over 90s for blood pressure, is 99% of room air. His BMI was 23. For his non-neurologic exam, he had no jugular venous distension or crackles, but he did have 2 plus peripheral edema to the thighs. For his neuro exam, I'm just going to read the neuro consult note. I'm going to do my best. Mental status was pretty unremarkable. Cranial nerves were pretty unremarkable. Um, Although he does have a right lower facial droop that the patient says is chronic. For the motor exam, he had moderate to severe atrophy of the triceps, forearms, FDI. I don't know what that is, quadriceps and intrinsic foot muscles bilaterally. So kind of diffuse muscle atrophy. There was cogwheel rigidity of both arms, worse with augmentation maneuver, worse on the left. He had irregular and slow finger tapping, worse on the left. He had some mild bradykinesia of the arms. He had 4 plus out of 5 strength in the deltoids, biceps, triceps, and flexors, extensors bilaterally of the arms, I'm assuming here. 4 minus 5 strength in the quads, hamstrings, dorsi and plantar flexors bilaterally. So basically mild weakness in kind of all extremities. For sensory, he had distal length dependent loss of pinprick in the feet and calves, but otherwise intact light touch and pinprick of all extremities. His reflexes, he had negative pectoral reflex on the right, positive pectoral reflex on the left, and then Hoffman's was negative bilaterally. And for his kind of presenting labs, he did have leukocytosis to 11 when he came in, a mild anemia at 10.6. His platelets were 324. CK was normal. For his BMP, his rather CMP, his albumin was low at 1.9, total protein 4.5. AST and ALT were normal. Alk phos is 1100 with a low vitamin D level at 12. Um, for his imaging, they just got a chest x-ray. He had these kind of lower lobe opacities. And then for his alk phos elevation, they got a CT abdomen without contrast when he came to the hospital. It showed no splenomegaly, no hydronephrosis. He had moderate pleural effusions bilaterally and anasarca, and he had large stool burden in the colon and rectum. And then for early interventions, he was put on benztropine, and this didn't result in any changes to his kind of weakness sensation. So I'll stop there for that aliquot.
Let me just make sure we got everything here. Diffuse atrophy, the strength we got in the, I was sort of listening as we go and watching the typing as we go. 4 out of 5 in the upper extremities and 4 minus in the lower extremities. Was that everywhere or was that
From
more
how
like,
I'm interpreting, yeah, from how I'm interpreting it, it was pretty much everywhere in the limbs because it lists off IP, quads, hams, dorsiplantiflexors. So I think 4 minus out of 5 kind of diffusely in the lowers, and then 4 plus out of 5 in the uppers is kind of what I'm
got it?
gathering.
And did we hear the reflexes outside of the pectoral and the Hoffman?
Actually, not commented on in the note, unfortunately. Sorry, neuro.
Yeah, if you're one of my residents, you'll know when I see reflexes deferred in the note, I sigh deeply. Please don't defer the reflexes. Yeah, the more you check them, the more you get better at doing them and understanding their subtleties and all they have to teach us. Okay, sorry for the soapbox. I like the reflexes. They're helpful. Um, but we don't have them to work with here. Okay, Sarah, Valeria, what's going through your minds?
I'm intrigued. I mean, this was a very big aliquot. Um, I think the first thing that jumped out at me was the right lower facial droop, because I think that one was the first thing that we've heard that was really a localizing sign. And we have both right-sided facial deficits, and then I think we had a right pectoral, oh, positive left pectoral reflex. So right face, left body, because you don't expect a pectoral reflex usually, I think, or you can. Um, but yeah, I think we are missing some reflexes that may be helpful. Um, The cogwheeling also interesting. Lots of like Parkinsonian traits on physical exam. Uh, but yeah, I think this is interesting. And then we also have the bilateral atrophy of the triceps too, um, which like is that just like deconditioning a person who has not really used their muscles very much in the last couple of months. I don't know what that time course would be for the atrophy. So, Valeria, what are you thinking?
Oh, and just real quick follow-up questions here. I think the atrophy was pretty diffuse, right, Andrew? I know we got a ton of information, not all of it. It was going so fast. I think not all of it was able to be transcribed in real time. But um, just for teaching purposes here, where does atrophy localize typically?
Usually it's like neuromuscular junction, so like peripheral nerve.
Yeah, usually peripheral nerve. Yeah, usually you won't get atrophy with neuromuscular junction, but yeah, peripheral nerve or very advanced muscle disease, and peripheral nerve. Let's not forget. Oh, I'll leave that aside for now, and we'll bring it up in discussion. Good. Yeah. So that's peripheral, or as you said, if the patient, you can get disuse atrophy in a patient with, you know, if the patient has a stroke or spinal cord lesion, spinal cord injury, and isn't using the muscles because they're weak, then you can get disuse atrophy, even though the lesion is central. But yeah, usually that's a peripheral process. Yeah. Okay, Valeria. What are you thinking? I'm lucky I get to go last here. I'm still thinking.
Yeah, honestly, I don't just like echo what Sarah mentioned. I think the atrophy for sure localizes more to like lower motor neuron disease typically, but can also be just like very long-standing you know, upper motor neuron disease. And I think I'm having a hard time differentiating the Parkinsonian component of it and being comfortable attributing it to the medication that was discontinued and or if this is something part of the um, that chief concern that we are trying to tackle now. Um, and I think for sure the four extremities are diffusely affected, so it's not like just a lower extremity problem. I think we were thinking about the spine and the fact that there's sensory compromise right now is making me doubt that hypothesis just because it's more commonly found with like neuropathy, for example. Um, so that's something that I would entertain the possibility of a polyneuropathy here. Um, I think I don't know how to interpret the pec pectoral reflex. I've never assessed that. So I'm not sure if that's a sign that could contradict our hypothesis of this being on the lower motor neuron. But I mean, I'm very sad that we don't have the reflexes on the legs to see, or even on the arms to see if, this also would make us think beyond more like a nerve problem rather than a spinal cord problem. So yeah, I think I would be very interested to still image. Oh, and then I will also layer on the labs that we have. So what do I do with this very low albumin, very high alk phos? I think alk phos makes me think about something on the like biliary tract or in the bones. And I think in the absence of any other like liver panel abnormalities, I'm doubting the disease on the biliary tract, but rather would be concerned about something on the bones, and that for sure can, compromise the spine. And like maybe uh, the bones of the spine could affect not necessarily the spinal cord, but the roots and the nerves going out from the spinal cord, and that could lead to this pattern. And then when it comes to the albumin, we recently learned from Ravi that albumin is classically associated with malnutrition. However, it's not necessarily that, but rather, a problem with the production of albumin, for example, through the liver, but also increase in its excretion, so like through the kidney. So just to say that I will be concerned about the bones of this patient, I will be looking forward to imaging the spine and to probably make a better assessment of the nerves, just to rule out the possibility of polyneuropathy here.
Yeah, great thoughts from both of you. There's a lot going on here. So there's diffuse atrophy, and that jumps out here. If that's really occurred over 3 months, something is moving very quickly here, or maybe the patient was developing atrophy for longer and only noticed it after a certain threshold. Um, so that really does suggest a lower motor neuron process here. We all said peripheral nerve, but there is another lower motor neuron condition we should think of. And let me try to lead you there. There is weakness. I agree that cogwheeling and the slow finger taps um, probably is just the drug-induced Parkinsonism and hard to square with a condition that would cause Parkinsonism and diffuse atrophy, though maybe Andrew's going to teach us what that condition is, but I can't think of one off the top of my head. There is some sensory distal length-dependent loss. You mentioned, Valeria, that sensory loss maybe puts you more in the nerves than in the spinal cord. You can get sensory loss from the cord also from getting the dorsal columns or anterolateral tracts. But distal length-dependent pinprick sensory loss, what does that usually signify? Like which localization? Yeah, sorry.
Like a smooth, well, not pinprick,
Yeah.
like
Just
so like the dorsal column.
yeah, usually distal length-dependent sensory loss is a peripheral neuropathy. The length-dependent.
Alpha, yeah, never
Yeah.
mind.
And the sensory loss here is really not that impressive compared to how severely impaired the patient is on the motor side. And the patient does have diabetes, um, and diabetes over 70 probably has some limb-dependent sensory loss. I'd be willing to actually separate that out because this patient had a severely progressive sensory motor neuropathy, bad enough that he'd be weak everywhere and atrophied. I'd expect a lot more on the sensory exam. So what do you make of something that seems peripheral nerve based on the atrophy? Seems peripheral, yeah, peripheral and not neuromuscular junction or muscle based on the atrophy, but not much sensory loss.
Like motor neuron disease.
Yeah, I think when we do this localization thing, we often forget about motor neuron disease because we're sort of, we have peripheral nerve as a category and motor neuron disease usually upper and lower. Yeah, there's all this atrophy. If sensory was normal and reflexes were normal, we'd wonder, is this a muscle disease? We haven't really gotten a proximal versus distal, but what's the saying? Maybe someone can check me on this. I always have to look it up. Severe atrophy out of proportion to weakness versus weakness out of proportion to atrophy. One of them is like more nerve and one of them is more muscle. I think weakness out of proportion to atrophy is more muscle. Somebody check me on this. And I remember hearing this pearl, like on a podcast I was driving or something. I was like, remember that, remember that. And then clearly I didn't remember it. But I think weakness out of proportion to atrophy is more muscle and atrophy out of proportion to weakness is more nerve. But someone can fact check me and let me know in the chat. I feel like I heard someone wise say one of those. It's important to know which is which. But this sounds a little more nerve-ish to me, though it could turn out to be muscle also. And if it's nerve and there's not really that much sensory going on and we have another reason for the sensory, the diabetes, the CKD also, does this patient have motor neuron disease hiding under all this? To get motor neuron disease kind of everywhere, we think all the motor neurons are affected in a disease like ALS, but the most common presentations are usually kind of in one limb and then it progresses in that limb and then spreads kind of around the clock to the other limbs. Though you can get bulbar onset in the muscles of the head and neck, you can get a paraparetic, or what is it, bilateral flail foot variant where it's the feet, bilateral upper extremity variant, flail arm, a sort of hemiparetic variant, I believe. Sorry for the background noise, there's some street cleaning today. And then it'd be really nice to know the reflexes, right? Because if you have atrophy and upper motor neuron signs in the same limb, that's kind of ALS, or if the patient's lucky, it's spinal stenosis with both cord and root involvement. But I wonder if that's what we're getting hinted at here with the pectoral. So the pectoral reflex, you can get it normally, but I think it's usually not checked unless someone's looking for signs of hyperreflexia. So is that a little clue that there's atrophy, hyperreflexia, and motor neuron disease? Now, motor neuron disease should not cause high alk phos, a low albumin, low vitamin D. Someone taught me recently low vitamin D can actually cause a myopathy, muscle disease. I haven't gotten to look into it and learn more about that, but someone can check and teach us in the chat here. And yeah, alk phos, good. For AST, ALT, it's liver, or many people don't know, it's also muscle. So if this was a really bad muscle process, you can see elevated AST, ALT in addition to an elevated CK. We don't see any of those. Um, so the patient's a little bit malnourished here, and the patient's constipated based on the CT. At least that's my neurologist read of the CT abdomen. So another thing, just to wonder, what would you do with malnourished and neuropathy? Does that ring any bells for anyone?
I mean, all sorts of B vitamins. B1, you get symmetric lack of reflexes in all of the like extremities. But I think like copper and B12 and micronutrients too.
Yeah, so B1, thiamine deficiency, we think of Wernicke's encephalopathy, but you can get um, beriberi, right, which is you can get a peripheral neuropathy that's pretty rapid. It looks kind of like a Guillain-Barré picture. You can get heart failure with wet beriberi, right? In fact, I think one of the first CP Solvers podcasts I ever heard, they were presenting a neurology case, and it was Robbie, and I think it was beriberi, and I was like, okay, I got to meet this guy. Who is this guy? I got to talk to this guy. Um, so I wonder, yeah, and then B12 deficiency, it's usually myelopathy or neuropathy or both, meaning spinal cord, nerve, or both. Um, Maybe that's the upper or lower motor neuron, but usually in my experience, the B12 deficiency patients, they don't actually get weak. Their disability is more from sensory ataxia from the dorsal columns, and they have upper and lower motor neuron signs, but they're usually not weak. Their difficulty moving is sensory ataxia. In my experience, I'm sure if it gets bad enough, it could be. So I'm wondering about I'm wondering about the peripheral nerves, specifically the motor nerves, and I'm wondering about a toxic metabolic etiology here related to malnourishment, something in the beriberi family. There is this, I don't know if A is here. This is something I learned when I visited WashU. I think they call it ANAN, acute nutritional axonal neuropathy, something like this. And it's sort of like B1, B6, B12. It's like a rapidly progressive, I think, motor, but I forget if it's motor sensory. I don't know if someone can look up. It's ANAN, ANAN. I haven't heard that term used elsewhere, and I haven't been able to understand from the literature if it's talking about something different than beriberi, or ANAN is like an overarching category of nutritional neuropathies, and beriberi is the specific one caused by B1 deficiency. If anyone knows, please speak up. I've found the literature a little bit hard to parse.
Aaron, I follow Marcus Pinto, who's a peripheral
Oh yeah,
neurologist
I know him.
at Mayo.
I know
Yeah,
him.
yeah, he has a great saying on Twitter that I have in my notes. Sometimes the patient needs IVT, IV thiamine before IVIG. That's kind of how I remember this entity of kind of a
Oh yeah,
Guillain-Barré mimicker. Yeah.
he's he's fantastic. Yeah, I back in the heyday of med Twitter, I followed him and I got to meet him when I was visiting Mayo. Yeah, he's a phenomenal neuromuscular specialist at Mayo. Um,
But
okay,
maybe I could give you guys a little bit more info. Yeah,
yeah, well, I was
yeah. You got
just gonna ask
yeah.
quickly. I know we got to move it along. I think we're doing okay with time based on the number of aliquots. But Vale, Sarah, what would you order? We have kind of like we're still not totally secure on our localization, um, and we're starting to wonder about motor neuron disease versus a metabolic. This would be fast, I guess, for motor neuron disease versus a metabolic nutritional neuropathy. Um, ANAN, there you go. Um, uh, what would you order?
Yeah, I think I would still want some imaging of the spine. Just rule out like an MRI. Like vitamin deficiencies. As Andrew mentioned, I will just give this patient thiamine. And then I maybe would want an EMG, so like nerve conduction studies as well. I think your thought about a motor neuron disease is really interesting because I've also read Andrew shared a case with us on one of the rapid fires about kind of an ALS plus syndrome. So that can, lead to like respiratory symptoms, but also in the spectrum of Parkinsonism. So like I think frontotemporal dementia is the one that is most associated with ALS plus, but I think Parkinsonism could also fit. Just trying to, make something
Yeah.
fit. But yeah, I think EMG neuroconduction studies are my priority too.
Yeah. And then I just had another. Oh, sorry, Sarah, you go ahead. And then I had another idea here as I keep squinting and reading the 2 point font of all the things we have on there.
Yeah, I guess I'll just emphasize my soapbox is that if you have any suspicion of B1 deficiency, to go ahead and start the IV thiamine. So I think prioritizing starting it before even knowing whether they're deficient, I think I would do. And then in addition to getting kind of those nutritional labs, but also I think I would want to actually go back into the room and get a more detailed physical exam before
Good
really
move.
localizing anything. And just given the ALK phos, I would want kind of a liver panel to see whether I can kind of figure out whether this is more of a bone or liver picture. Um, so maybe those for labs, at least to start. Um, but yeah, agreeing with Valeria for everything else.
Yeah, and something else is coming to mind here as I my eyes keep tending to go back to the neuro exam and try to squeeze something else out of it, but I forced myself to read the CT abdomen again. And what if we lump things in different ways? Some of you have heard me talk about, we talk about lumping and splitting, Occam's razor versus Hickham's dictum, but I find it very helpful in these really hard cases to just very deliberately put all the pieces on the table and just like rearrange them in different ways, or take something off the table and say, does this something pop out? Let's take the Parkinsonism off the table. I think we've done that maybe to our peril, but fine. Um, we've been kind of avoiding talking about the medicine except to say the patient's malnourished, and maybe the malnourishment is the anasarca, but what if we call that anasarca peripheral edema? And there was some peripheral edema on exam. What if we say peripheral edema, pleural effusions, there's this constipation, maybe an autonomic neuropathy, there's motor neuropathy, or any conditions jumping to mind? Something popped out a little bit to me here. Or another way to ask you, let's say this is a neuropathy, not motor neuron disease. It's moving quickly, right? Months that it's this bad. What can cause neuropathies that evolve over months? And or neuropathies over months and peripheral edema and lots of medicine stuff that neurologists are having trouble explaining. It's a little bit guess what I'm thinking.
Like metastatic processes, or
In the family of, yeah. Yeah, so when I see a rapidly progressive neuropathy, not as rapid as Guillain-Barré, but fast, like subacute, that's always a red flag that this is not behaving normally like a usual diabetic neuropathy or something that tends to progress a little more indolently. Um, I think of two major categories. One is CIDP, the chronic immune demyelinating polyradiculoneuropathy, and the other is paraprotein associated neuropathies. Probably we should put nutrition. I should put nutritional in that category as well. And paraprotein associated neuropathies are a whole topic. If you want to read fantastic article, where in 3 weeks you'll be able to read a fantastic article in Continuum about this by my colleague at UCSF, Mark Terrelong. But the old continuums on this are very good. And then there's some classic papers in New England Journal by Alan Roper, one of my mentors, about this, and two beautiful CPCs in which he discusses the diagnoses that sort of come to mind as a possibility here, which is POEMS syndrome, polyneuropathy, organomegaly, endocrinopathy, M spike, and skin changes. We haven't heard of many of those things, but there's kind of like a fast neuropathy and medicine. I think about the paraprotein associated diseases, like POEMS. Rabia and Reza once got stumped by, I'm blanking on her name, the New York Times writer, of a case that was like neuropathy and heart failure was the short summary. That was TTR amyloid. I don't think they get all this medicine stuff. So I'm starting to move away actually from motor neuron disease and wondering if all this, the medicine stuff here, is a paraprotein associated condition like POEMS. There's a whole table of these. Waldenstrom's can do this. But something in the family of POEMS. Clues to POEMS: you can sometimes see papilledema. They have an elevated VEGF. But I agree, if we're not totally clear on the localization, this is a great case for an EMG to say, hold on, is this motor neuron disease? Is this neuropathy? Is this some of both? If it's a neuropathy, is it axonal? Is it demyelinating? Is it length dependent, which would make it more likely to be axonal? All these kinds of things. So I think that would be a helpful test here. And that would probably be the next branch point from my perspective. But okay,
Awesome.
go ahead, Andrew.
Awesome. It's amazing how much progress you guys can make with such minimal information. So let me give you all what you're asking for. So he got a MRI brain. It showed subtle hyper enhancements of the right facial nerve. An MRI spine showed enhancement of cauda equina and sacral nerve roots. And then due to need for EMG and nerve conduction study, he was then transferred to my hospital. An LP was performed, only one nucleated cell. Protein was 85, glucose was 76. And now I'm going to give you like a time course on the span of kind of weeks to months, because this is where things are kind of interesting. So after he arrives to our hospital, he actually goes to the ICU for fever and hypotension, kind of concerning for septic shock. He has E. coli bacteremia, and he eventually stabilizes and goes back to the floor. They actually start him on IV or no, they felt his weakness was improved, so they defer IVIG. He's then discharged to rehab actually. And then just days into his rehab stay, he starts feeling unwell again. So he goes back to the hospital and he's found to be in septic shock again. And he's re-imaged and found to have clear stercoral colitis this time. He gets better with antibiotics. And then, despite an aggressive bowel regimen, a week later, he again basically goes back to the ICU in septic shock because of stercoral colitis. So, this is like three ICU admissions related to stercoral colitis. At this point, he's having frank dysphagia, now requiring tube feeding, despite having a okay mental status, although everyone comments he's like quite deconditioned at this point from having so many ICU stays. He does get an EMG. It's limited by anasarca, but it shows some myopathic motor units, is what it says. And then he gets an MRI of the thighs, and it shows muscle edema and corresponding interstitial contrast enhancement bilaterally, and then muscle atrophy, which we kind of already knew about. So I'll stop there. And then for timing purposes, there are two more aliquots, with the latter aliquot kind of having the final test that will lead to the answer.
Okay, Vale, Sarah.
Yeah, this is a lot. I think, per patient that's having severe autonomic dysfunction that's leading to all this recurrent septic shock. So like the sterocolitis is due to like the accumulation of the or like stretching of the colon because they cannot poop. And then we also have some bulbar symptoms that are getting into this new syndrome. And Andrew, could you repeat what the findings on the EMG were? I didn't hear correctly.
Myopathic motor units is the predominant finding.
Okay. Yeah, well, I'm not really sure what that means necessarily. I hear the word myopathic, so I'm wondering if, that leads to a muscle process been going on here, which would for sure be kind of odd because we were rooting for the nerves. But then again, if there's like profound atrophy, the nerves may not conduct anything. So I would be interested to see on the exam if this patient has any movement at all, or if we're seeing still the predominance of atrophy versus weakness. So yeah, I think weakness plus bulbar symptoms plus dysautonomia make me think about like severe nerve disease, like we nerve track, or something. And then we also have the enhancement on the cauda equina, now that I remember. I'm wondering if the enhancement is on the spinal cord itself, like we have some axial cuts to see if, the gray matter is affected, or if it's something on the meninges that is causing like the enhancement. I will be concerned about that just to, I think, make more progress. But I'm really stumped. I'm not sure. What are you thinking, Sarah?
Yeah, maybe we'll let Sarah do the next aliquot just in the interest of time, since we have one more, if that's okay. Um, yeah, when we got to the enhancement of the cauda equina nerve roots, you can see that with Guillain-Barré, CIDP, other neuropathies. They are CIDP both, and Guillain-Barré. The P is not polyneuropathy; it's polyradiculoneuropathy. So those roots can enhance. The high protein at this age, you can get some spinal block, or it could be subtle inflammation. So I thought we were on track here, and then the EMG showed myopathic motor units, which means it's a muscle disease, and then the MRI shows muscle edema and enhancement. We're using MRI more in the diagnosis of myositis. and that can suggest intrinsic muscle inflammation and myositis, though you can see T2 hyperintensity. I don't know about the enhancement, just from denervation also, so even that is not a perfect test. Um, and then the dysphagia, hard to know. He's in and out of the ICU, septic, getting intubated a lot. I'm not sure if that's part of the whole thing or not. But we're certainly not seeing the EMG is obviously limited if the patient has a lot of peripheral edema. We're not seeing clear signs of neuropathy or motor neuron disease aside from the enhancements of the cauda equina, which suggests a nerve problem. So we're in a little bit of a difficult place. I agree with you, Valeria. Where either we say our initial hypothesis was nerve, there's nerve, and now he's been in the ICU a bunch of times. Does he have a sort of critical care associated myopathy where patients can have muscle findings? It can have critical illness neuropathy. I think now the umbrella term is critical illness associated weakness. Is this all critical illness associated weakness and a very hard to perform EMG in a patient who's uh, very edematous and very ill and in the ICU, not in the controlled environment of the EMG lab? And do we stick with all that atrophy first and maybe the bulbar is part of motor neuron disease and this is now something else even, but we're sort of stacking a lot of stuff. And if this was a muscle thing the whole time, and it's this fast, and there's contrast enhancement, I guess it's an inflammatory muscle disease, a myositis. Um, and in this age, yeah, I guess you would. Well, he's on a statin also. Does he have an immune-mediated necrotizing myopathy from his statin? But that wouldn't explain the bowel problems or the cauda equina. So I don't think there's a unifying thing here. I think everything's yeah. I'm feeling more Hickham's dictum than Occam's razor on this. I guess if the neurology team was really convinced there's not a nerve explanation, then the patient would probably get, well, you'd stop the statin in the meantime, and you'd get a muscle biopsy, and you could send the antibodies for immune-mediated necrotizing myopathy, which are anti-HMG-CoA reductase and anti-SRP signal recognition particle. Um, the patient's pretty sick. Probably you're going to end up getting a muscle biopsy, and while you're in there, maybe take a little piece of nerve and um, settle the thing here. But there's another aliquot even before we do that final test. So okay, and we're running out of time. So I see ancillary signs of muscle disease, but clinical and MRI signs of nerve disease or root as a sort of which is part of the nerve. I'm not sure how to square those. I'm not sure what's now layered on from critical illness and what's sort of pre-existing. And the bowel. The bowel is not muscle disease, right? And the bowel is not motor neuron disease either. Um, I'm
Yeah.
I'm going in circles. Give us some more information, Andrew.
Yeah, I think this was kind of the crux of the case, is my understanding, kind of that tension point you guys are describing. SPEP and immunofixation showed no monoclonals. Light chains were not sent. VEGF was normal. RF, rheumatoid factor negative, HBV, HCV negative. Basically, vitamins were all normal. The myositis Mayo panel came back with a low positive for anti-NXP2 antibody, and the inclusion body myositis panel, I think it's just one antibody or two, was negative. Muscle biopsy showed scattered atrophic fibers without substantial inflammatory infiltrate. And then a PET CT showed basically what they thought was physiologic uptake in the strap muscles. Otherwise, there was no abnormal uptake in the muscles or lymph nodes. And I'll give you a couple more blood tests for the final diagnosis in the last aliquot.
The muscle biopsy was what? Sorry.
It was scattered atrophic fibers, but no substantial inflammatory infiltrate.
Okay. Sorry, Sarah. This is the one you got. Can you make any sense of this?
Yeah, I think I would be reaching out to people who have more experience with the myositis panel. These panels have so many things on them, and yeah, calling the lab and asking them for more information on how to interpret it would maybe be my first step. Um, Taking that in context with the muscle biopsy that doesn't actually show any inflammatory, that could mean that either there isn't an inflammatory process happening or we just didn't capture it in the biopsy. Um, But yeah, I'm interested to know what you think.
Yeah, I don't know what I think. Yeah, we got the SPEP. There's not a
Yeah.
gammopathy, so that makes poems pretty unlikely. I think it's IgA lambda in poems, but the papers I mentioned have beautiful tables of which Ig subclass and which light chain are with each of these paraproteinemic neuropathies. Then the VEGF is normal. I'm not sure how sensitive it is for poems, but that was fun to talk about, but seems off the table. NXP2 is one of many dermatomyositis antibodies. This whole idea we learned in med school, dermato versus polymyositis, the neuromuscular folks aren't really been sure polymyositis is a thing, and it's just dermatomyositis. The atom keeps getting split with more antibodies. There's a syndrome now called antisynthetase syndrome, which got split off from dermatomyositis, and then each of these antibodies, NXP2, there's a whole bunch of them. I don't have them memorized that have different associations with interstitial lung disease versus mechanics hands versus Raynaud's versus high likelihood of finding cancer. I think NXP2 has a cancer association. I could very well be wrong. I have not memorized these, and they keep evolving. So as you said, ask an expert. And I don't know what to make of the low titer, and I'd have to look that up. Or when you send them any Mayo panel, when you can call Mayo and you'll get a physician who will tell you how to interpret the panel. It's a pretty cool feature of all the money your hospital pays for sending stuff to Mayo. And then atrophy with no inflammation. I mean, we're not hearing about inclusion bodies and not hearing about um, uh, uh, necrosis. Don't know what to do with that. Is the anti NXP2 low titer red herring that atrophy is just this patient has critical illness myopathy, and we were right that there's motor neuron disease buried under here? And we ask our medicine folks to diurese the patient and let us get a better nerve conduction study. I'm really not sure. And then Andrew said it's a blood test that's going to give us the answer. I don't know what
Yeah.
else. Anyone, Valeria, Sarah, any blood tests you'd like to send if you were at the blood test grocery store and able to put anything in your cart here? I'm not even sure what I would request. I guess you could repeat the NXP2. The myositis panel has all the other tests I would have mentioned, and there's no blood test for motor neuron disease. Um, and why is he? If this is a muscle disease, what's going on with the cauda equina? What's going on with the bowel? So we can't have our cake and eat it too here, for lack of a better metaphor. We can't. I can't square all this stuff, and I can't think of a blood test that would help me square even one part of it. Um, but I guess we're gonna learn. I'm sure we're gonna learn something. Valeria, any?
No, not really. I'm ready to learn from Andrew as well.
I think I'm ready to learn. Sarah, anything you'd like to
Yeah, I mean, we haven't heard much about like the toxicology side, maybe like heavy metals, in reaching out to tox.
Heavy metals, always a good thought in undiagnosed neuropathies, if there's a neuropathy here, which we still haven't been able to objectively confirm. Uh,
Oh,
what else?
all right.
Okay, yep, you
You
got
want me
us,
to give the
Andrew.
real?
Well done.
Aaron, I know you have to go, so you can
No,
tell
no,
this case
totally
was
good.
hard because they got like every kind of test under the sun to clarify what was going on. So there was a heavy metal screen. It was negative. A neurofilament light chain, which apparently is a biomarker of neuromuscular disease, very nonspecific, was very positive at 365 picograms per mil. The upper limit of normal is 35. Ganglioside antibody panel showed a positive IgG for GD1B and IgG to GM1 and IgM to MAG and IgM to histone H3. A demyelinating neuropathy panel. This has a couple of things, including neurofascins, contactins. That was negative. They got a paraneoplastic antibody panel kind of in conjunction with the PET scan. This includes the voltage-gated calcium channel antibodies that was negative. So I guess all in all, people were really worried, given the tempo of this that was commented on being very fast for this patient, that this was going to be some sort of paraneoplastic disease, which is kind of what prompted the PET scan. But in conjunction with the paraneoplastic panel being negative and the PET CT being negative, that essentially kind of ruled that possibility out. But the question really became like, what is the significance of NXP2 antibody being positive? Because when I saw that, I thought that this was just going to be like a simple myositis case, but neurology and rheumatology were like, whoa, slow down. What's interesting is for one study, the NXP2 antibody, even if it's a low titer, still carries as much diagnostic significance as a high titer, because usually you need high titer myositis antibodies for it to be clinically significant. But even with that in mind here, the neurology team thought there was a kind of strong enough disconnect between the objective evidence of myopathy here being on the lower side and the objective evidence of neuropathy being on the higher side, that this was likely the NXP2 was likely just kind of an incidental finding and not really clinically relevant. So they felt that this was kind of an immune mediated neuropathy. And it's really fascinating because there are like a lot of antibodies to know, but I would just summarize based off of what I was reading about immune mediated neuropathies. We've learned a lot in terms of like stratifying CIDP into particular kind of immune phenotypes, and you can kind of organize antibodies by the anatomical structure of kind of the node of Ranvier in terms of these like nodopathies, paranodopathies. So there's a long list of these things. Since we're running low on time, I'll not share all of those antibodies, but I can certainly drop a couple papers in the chat that describe this kind of grouping of diseases. Each of the antibodies in this group of diseases kind of carry particular clinical phenotypes, I'll just say. But I think some of the commonalities, and hopefully I don't overreach here in terms of my very minimal expertise on immune-mediated neuropathies, is these are often pretty like treatment refractory to like simple IVIG, or at least some of them are pretty treatment refractory. And they think that they're really more like IgG4 antibody related. So people are really moving more toward like B cell depleting therapies like rituximab to treat these patients if they have a lot of clinical progression. And then another interesting feature of kind of these immune-mediated neuropathies at the node region is apparently like on pathology, they look pretty like clean. So like even though they fall under kind of the bucket of CIDP, like inflammatory demyelinating, like on pathology, they don't look that significant because I guess these are just like purely kind of antibody mediated disease. They don't like look that way. That's kind of my scattered reflections on this case. There's certainly a lot to talk about. Curious what you all think about that.
So, did neurology make a final diagnosis?
They were kind of treating this as just like immune-mediated neuropathy. Unfortunately, the patient just got so sick from the repeated ICU admissions that kind of serial complications happened, and he passed away like 6 months after this kind of all went down. So there's no kind of like singular diagnosis in the chart for this patient. They just treated it as an immune-mediated neuropathy, but they didn't escalate past IVIG because after he did ultimately get IVIG, but his weakness thereafter kind of stabilized and other issues kind of took center stage. So they didn't talk about escalating therapies for him or anything.
Got it. Yeah, it's interesting to see the same problems we were wrestling with, Vale, Sarah, and myself. We're like, there's lots of stuff going for neuropathy, but there's some ancillary tests going for myopathy that they were wrestling with the same things and ultimately thought the clinical picture, the enhancement of the cauda equina, that's nerve stuff. And the muscle stuff a little harder to square. So they never got a clear nerve conduction study, Andrew, that said either this is demyelinating axonal. No. Okay. Yeah, I'm not sure what to do with the NXP2. Yeah, I would have to look that up and talk to people. Are you allowed to have even a little? Like, you're not allowed to have even a little NMO antibody. If you have it, you have NMO. Whereas if you have a serum NMDA antibody, some people have that incidentally, and it's really only significant in the CSF. So I don't know for NXP2, are you allowed to have it even a little bit, and if not, what it means. But that would not explain the bowel, and that would not explain the cauda equina. However, well, the only way to diagnose CIDP, it's a syndrome, there's no biomarker, is with a nerve conduction study, or a nerve biopsy, I should say. These paranodal antibodies you mentioned, neurofascin, Contactin, those were sent, which is a good thought here. I don't know if they can do all this autonomic stuff. I've only seen a couple cases, and Kirtan presented us a case. I've only seen one personal case, and I've heard about cases, and Kirtan presented a case here probably a year or two ago. But those antibodies were negative, so it's not that. And then the neurofascin light is like a neurologic CRP, ESR. It's just like the nervous system is upset, is injured. It's a very non-specific. I think you can correct me if I'm wrong. Even get it in head trauma. So it's bad when it's high, but it's not really giving us direction in this case. Then the ganglioside antibodies are interesting. GM1, I think, is associated with multifocal motor neuropathy, which is sort of a cousin of CIDP. It's an immune mediated motor neuropathy, but it usually doesn't present symmetrically like this. I've actually never seen a case, but it presents as mononeuropathy multiplex, like a wrist drop on this side, a foot drop on that side, that kind of thing. Um, and it doesn't cause all this bowel, cauda equina, all this stuff. I've never heard of the histone one. MAG is associated with DADS, distal acquired demyelinating sensory neuropathy, I think is what that stands for. And it is what it sounds like. It's distal, it's acquired, and it's sensory. It looks length dependent, so people think it's axonal, but it's demyelinating and it's associated with anti-MAG. But I don't think of it as causing this sort of, well, it's sensory, right? So we didn't have any motor. So I don't know what to do with those antibodies. Andrew, did neurology say, oh, one of these tells us something, or once the nerve has been injured and inflamed, is it kind of, are cryptic antigens of the myelin being exposed, and these antibodies are epiphenomenon rather than cause? Did neurology opine on those antibodies, or did they enlighten you in a different way about the neurofilament light? I see that as like a CRP. It's high and something's going on, but it's not, specific.
Yeah, no, they viewed it the same way. And there was low confidence, I think, in what to ultimately call this, Aaron. I only saw this patient for like a week on medicine, and I kind of just followed their course thereafter. And all of the neurology, because he did actually follow up in neuro clinic after one of these hospitalizations. They did feel that kind of the ganglioside panel was significant and kind of what was driving what was going on, but they didn't put a name on it or anything like that.
Huh. You got me. And what did they think the bowel was related, or just this guy became immobile and stopped moving and got constipated, and he got into some vicious cycle of constipation, stercoral colitis constipation, or is that
Yeah, I don't
is that
know.
neurology? Late onset
Yeah.
Hirschsprung?
I was hoping to learn from you guys about that because it was so striking, clinically speaking, that I thought it must be related. And that's actually why I got really excited about the myopathy panel coming back up positive, because I thought that like intestinal myopathy and like proctitis could be results of kind of poor movement from muscle disease. Yeah, I thought surely it has to be related, but at the end of the day, I'm not sure if it was related. It certainly could have just been just poor mobility deconditioning.
Yeah, it's striking that that's really the only autonomic feature here. And then there's the anasarca, there's the we went never got back to the cough, there's the orthopnea, all that stuff. Sounds like there's something cardiovascular going on here. I don't know. Did they send? I've never seen a case, so I don't know if this even fits for us. Did they send TTR amyloid genetic testing?
No, no TTR.
What was the heart? Was it? Was it?
We we thought the cough because he did have aspiration pneumonias. We think that the nocturnal coughing was from aspiration that was going on at home from just weakness.
And all the peripheral edema? What was the medicine explanation for that?
That was the most unclear thing. He didn't come in super hypoalbuminemic, I'll say. I think it was like in the twos. And then as he was in the hospital longer and longer and getting these infections, his albumin just kind of tanked, which really muddied the water because he kept getting treated for stercoral colitis. But no, his very presenting edema, I'm not sure. He did come in malnourished, so it could have just been that. But he didn't have like nephrotic syndrome. We actually did check the urine protein. He didn't have heart failure and he didn't have liver disease. So it was probably when he came into the hospital a little malnourished. And then thereafter, he just capillary leaked everything because he
I
got
see.
really sick.
And thiamine never was thiamine sent. It takes forever to come back, but
Yeah, vitamins were normal. Yeah, they ended up coming back normal.
okay. Well, six cerebral hemispheres here could not sort this out, and so I'm glad to know your colleagues. Remind me where you are again, Andrew.
At BI right now. I'm glad you guys had fun. It was a
You're at
really hard
BI.
case.
Okay. Yeah. If Beth
Yeah.
Israel couldn't figure it out, we are reassured that six combined cerebral hemispheres here could also not sort this one out. But lots of good, things to wrestle with. I'm glad we were wrestling with the same stuff as your experts there in Boston, and I'm sorry that none of us figured it out. But I was like, what are we missing here? Where something's going to come back and we're going to answer this? And I guess the answer was nothing came back and we couldn't answer it, which does happen sometimes. So it's good to discuss a case like that is real life, right? Does not end as cleanly on some drum roll, please diagnosis. Good. All right. Thanks for bringing this very challenging case. If any further insights emerge, please let us know. Thanks, Valeria and Sarah, for discussing very expertly a very, very complicated, challenging case with no diagnosis. And I think, yeah, the main thing we played with in this case, which is worth thinking about, is lumping and splitting, and not just as a general principle, but like really putting your cards on the table and saying, like, what if I put A and B together and C and D together? Can A and B be something? Can C? Okay, swap them out. How about A and D? How about A, B, and D? How about C is like chronic and we forget about it? Just keep juggling things in these cases. That's the only way I can find to make diagnostic progress. That's where the idea of poems came out, and I think, oh, we could send, these tests for poems, and like, oh, well, it's a fast neuropathy. If I just look at that piece, we haven't sent the neurofascin, the paranodal antibodies. So sometimes you say, I don't know what to do with all of this, but I know what to do with this. I need to keep working this up. And then we say, I don't know what to do with constipation medicine. Hey, GI, what's this? And, tell us, is it neurologic? Do we fold it in, or it's something else, and we take it out? So that's kind of the diagnostic reasoning tool we were playing with today. We didn't get there, but I think it helped us at least at certain points say, like, well, there's muscle stuff. I don't know. That doesn't seem to explain it, but we got to work it up. And I know how to work up a myopathy, so let's do that. There's nerve stuff. It's fast. I know how to work up a subacute neuropathy, even if I don't know how to explain everything else. So just things to keep in mind. If you're interested, I think it came out in the last year. I wrote a little about this, like lumping and splitting, in a paper for Practical Neurology, the British journal, called Diagnostic Reasoning in Challenging Cases. If people are interested, not trying to promote my own papers, but it gets at what we do in these cases where there's like lots of elements and we can't figure out how to put them together and take them apart. It has a couple of cases and ways that we were fooled and how we might have looked at the case differently. If people are interested to read it, I'd love to hear your feedback. It's floating out there and online in a British journal. I'm not sure anyone has read it, so if you read it, let me know what you think. All right. Any final thoughts, Andrew, on this, or reflections from you and your neurology colleagues here at BI?
No, great work. I think it was really cool to see how much progress you guys can make before all of the tests kind of made things even more confusing, because you're on the right track with that. So love to see you guys discuss.
It was a lot of fun. Okay, thanks, Andrew. Thanks, Vale. Thanks, Sarah. We'll see y'all again soon. Bye.
Bye.